This is a short presentation on sepsis and DIC. I realized when working up the cancer and the clotting problems that we cannot really talk about them without at least mentioning and learning something about sepsis, which can result in the DIC cascade. So this is a short presentation. If you learned about sepsis in previous courses, it's a refresher. And if you haven't learned about sepsis, it's a good learner, I hope. That's my goal. The objectives to this particular module will be that you will understand the staging of infection from local infiltration to septic shock. You will develop knowledge of the prevention measures that will limit the development of this infection cascade. Student will know how to properly assess for the development of this infection cascade. You will have a basic understanding of treatment of sepsis and septic shock. We understand DIC and its pathophysiology and understand the unique challenges that DIC presents to recovery. The student will also be able to transfer knowledge gained from this module to the cellular regulation concept. Let's first talk about the pathophysiology of sepsis. It starts with the local stage. It begins as a localized contained infection. The key word here is contained. White blood cells secrete cytokinins that trigger local inflammation, which brings more white blood cells to the area of injury, and that's how it fights off infection locally. This results in constriction of small vessels and dilation of arterioles in the area, which causes an increase in perfusion. Capillary leak occurs, which allows plasma to leak into the tissues, resulting in the swelling that we get when we have a cut or a localized infection. The benefit of the inflammation is that it is limited only to the area of infection and stops as soon as it is no longer needed. The sepsis stage is that which happens when the local infection escapes out from the local site and enters the bloodstream. Sepsis is the presence of infection systemic manifestations. Infectious organisms have entered the bloodstream. This results in a widespread inflammation throughout the body called SIRS, Systemic Inflammatory Response Syndrome, which is triggered when the infection escapes that local control. Now inflammation is the enemy of the entire body. It leads to extensive hormonal, tissue, and vascular changes, which further impairs oxygenation and tissue perfusion. This results in a widespread vasodilation and blood pooling. The symptoms that you would see at the sepsis stage are hypotension, low urine output, and an increase in respiratory rate. These are all compensatory mechanisms that happen in that initial stage. It's a hypodynamic state with a decrease in cardiac output. In the sepsis stage, inappropriate clotting with microthrombi form in some organ capillaries, which causes hypoxia and reduces organ function. This problem is very hard to detect. The symptoms are very subtle, but if stopped at this point, organ damage is completely reversible. If it is not stopped at that point, it goes into the severe sepsis stage. This is defined as sepsis plus sepsis-induced organ dysfunction or tissue hypoperfusion and amplified SIRS. All tissues are involved to some degree throughout the entire body. Some organs are actually experiencing cell death and dysfunction at this time. The microthrombi formation is widespread, with clots forming where they are not needed, resulting in the disseminated intravascular coagulation syndrome, otherwise known as DIC. Platelets and clotting factors are almost completely used up. The amplified SIRS and cytokine release increases capillary leakiness, which injures cells, reduces anti-clotting actions, and triggers the formation of even more small clots, and therefore increasing DIC. Continued stress causes continued release of glucose from the liver, and so hyperglycemia will occur. The symptoms of the severe sepsis stage are negligible. Compensatory mechanisms cause a hyperdynamic cardiac function and resultant increased cardiac output. So the heart rate's going to go up a bit, the blood pressure will get better, the extremities will be warm, they will not show cyanosis because the blood the cardiac output has increased that circulation. The patient may actually look better, but do not be fooled. The white count actually will go down in this stage, and that's because the bone marrow's ability to keep producing them has been exceeded. Clinical manifestations that you will witness will be lower O2 sats, a rapid respiratory rate, decrease to absent urinary output, and a change in the patient's cognition and affect. Aggressive treatment at this stage can still prevent shock. The next step is a rapid decline leading to septic shock. Septic shock stage, it is defined as sepsis-induced hypotension persisting in spite of adequate fluid resuscitation. You now have multiple organ dysfunction syndrome called MODS, and that has become evident. There's very poor clotting with uncontrolled bleeding going on. It's a very high death rate at this stage. Severe hypovolemic shock and hypodynamic cardiac function occur as a result of the blood's inability to clot. Platelets and clotting factors were all consumed earlier. So basically, they're bleeding out. There's nothing. They're just bleeding out. The etiology of sepsis is bacterial infection that escapes that local control. Its increased risk is in immunosuppressed patients. And I refer you to the table in the IGGI book on page 751, the table 37-4. Look at those conditions that predispose a patient to sepsis. It's worthy of noting and being aware of those. Incidence is increasing due to drug-resistant organisms and the fact that patients are being discharged much earlier than previously. Prevention is of utmost importance. Evaluate all patients for risk factors. Use aseptic technique during any invasive procedures. Use aseptic technique especially when working with non-intact skin and mucous membranes of the immunocompromised patients. Remove indwelling catheters and IV access lines as soon as possible. Wean patients off the mechanical ventilators as soon as possible. Always keep the possibility of sepsis in mind when caring for patients. Early detection is a major nursing responsibility. We also need to teach the patient and family members what to look for when they're discharged. It may happen after they get home, and they need to know what early signs are. This is a brief overview of the assessment findings on different body systems. Cardiovascular, it differs in the different stages. If you remember, in early sepsis, the cardiac output and blood pressure are going to be low. So you'll have that early indication that things are low, what's going on here. Then you get that what appears to be recovery stage, which is really severe sepsis, and that's where the cardiac output, heart rate, and blood pressure are higher. It gives you that false sense of we're getting better, but they're not. Then the rebounding back down into septic shock occurs, and the cardiac output and blood pressure are very low. Respiratory changes are compensatory at first. Initially, the rate will increase and the depth of respirations will increase. They are susceptible to adult respiratory distress syndrome with septic shock, and this would have a very high mortality rate if they get ARDS. Skin changes in the severe sepsis stage. Remember, that's that rebound stage. It's going to be warm and without cyanosis. But then the next stage, that septic shock stage, it's going to become cool, clammy with pallor, mottling, and cyanosis. If the patient develops DIC, you're going to see petechiae and ecchymosis anywhere. And the gums, mucous membranes, venipuncture sites, IV catheters all may have evidence of easy bleeding. They just bleed very easily. The kidney changes are going to be a decrease in urinary output, and this actually may be the first sign. So if you have been evaluating your patient and their urinary output becomes very low all of a sudden, be suspicious. And when I say be suspicious, there's a test that can be done to help determine if sepsis is occurring, and that's the blood levels of protein C. If they are low, then that will indicate the presence of sepsis. Protein C is an enzyme that prevents inappropriate clot formation. It is activated when it binds to healthy vascular endothelial cells. It's a good thing to have. In severe sepsis, though, the injured endothelial cells cannot activate the protein. Thus, thousands of small clots will form in the capillaries of vascular organs. So decreasing levels of activated protein C indicate the beginning of severe sepsis even before other manifestations are evident. So keep that in mind if you're taking care of a patient who you have suspicion of. The protein C would be your early diagnosing factor. What's the treatment of sepsis and septic shock? Let's identify it early. That's the best thing. Correct the conditions that are causing it and prevent complications from it. Hospitals have developed what are called sepsis resuscitation bundles, and those need to be initiated within 6 hours as a standard of practice. A bundle is a group of 2 or more specific interventions that have been shown to be effective when applied together or in a sequence. Oxygen therapy, of course, drug therapy, specifically drugs to enhance cardiac output, restore vascular volume, combat sepsis, to deal with the adrenal insufficiency, hyperglycemia, it's going to be your insulin, clotting problems, the insulin therapy, and heparin therapy. Also, blood replacement therapy to include platelets and clotting factors will be used. Talking specifically about DIC now, says sepsis is a contributing factor to its development. Cancer patients are at an increased risk for infection due to low white count and immune function, which is impaired. DIC is a problem of the blood clotting process. When sepsis is present, vessel walls are impaired and extensive abnormal clotting occurs. This widespread clotting depletes the existing clotting factors and platelets, resulting in more bleeding. You have microclots everywhere throughout the body. These clots block blood vessels and decrease blood flow to major organs, which results in pain, stroke-like manifestations, dyspnea, tachycardia, reduced kidney function, and bowel necrosis. DIC is a life-threatening problem with a high mortality rate. The best management of sepsis and DIC is prevention in the first place. Identify those high-risk patients, practice strict adherence to infection control practices, and teach patients early signs of infection and when to seek help. The management of these problems is to reduce infection and halt the DIC process. IV antibiotic therapy needs to be given. In the early phase of DIC, anticoagulants are given, such as heparin, to limit this clotting and prevent that rapid consumption of circulating clotting factors. When DIC has progressed and hemorrhage is the primary problem, clotting factors are then given. A way to review this, what I encourage you to do are these 5 things. Describe, write it down on a paper. What are the stages of infection from local to septic shock? List the risk factors for sepsis and septic shock. List at least 3 nursing actions you can take to prevent septic shock. Tell your classmate what causes the DIC cascade of events, what starts it and what treats it. And now tell your roommate what he or she would need to look for if he or she was discharged post-surgery to prevent sepsis at home or to identify it early. What would you tell her? Do it now. Tell your roommate how to prevent sepsis.